Hi, thanks for being here. I'm Tagg Gauvain. I'm one of the UT orthopedic foot and ankle surgeons. I practice down in Pearland, team physician for Dawson High School. I've been in practice here at UT for 6 years now. I'm here with my partner, Michael.
Thanks, Doug. So I'm an orthopedic foot and ankle surgeon as well. I practice have an office in Sugar Land, Bel Air, and the Medical Center. I work with the University of Houston as one of their team physicians and act as a foot and ankle consultant for Houston Baptist University and St. Thomas University as well. So I think our plan today was to have an informal discussion about some of the more common injuries that we see, one being ankle sprains. So I know this is something that you see. How often do you figure you see an ankle sprain per day in clinic?
Probably one of the more common injuries that comes through the door. I'd say walks through the door, but sometimes it's limps through the door, comes in on crutches, One of the most common reasons people end up in the ER is ankle sprains. It's right there at the top. There's about 20,000 a day of these that are occurring. And a good percentage of those end up in our office because of some bit of swelling, pain, need for follow-up. But I see this very frequently, and it's all ages too, and all activity levels.
Yeah, I agree. So it is certainly one of the most common things that I would see in my clinic, and they do present. It's all ages. It could happen in a middle-aged person who just takes a bad step, or some of our more elite type athletes or high school athletes, and they all present a little different. And I think that sometimes the management has already taken place as far as they've been seen in an ER or an urgent care or by the primary care physician, and sometimes they literally just find us as their first stop. And we all have a similar approach to treating these injuries. What's the first thing you would do for a patient who comes in with an ankle sprain?
So the first thing I like to do is, one, figure out how it happened, get a sense of which way the ankle turned, just to sort of key in on where you might have the injury, and some of that key is where's the swelling, where's the bruising. And a lot of times that's the reason they come. You can sprain your ankle and have a little bit of pain and walk that off. But when people get bruising and they start to swell up, they get a little bit more worried. And so I tend to sit them down and do an examination of the ankle to try to figure out exactly where they're hurting and where they may have injured themselves. And most commonly it's lateral, right? It's on the outside of the ankle. Patient shows up and they've got this big area of swelling on the lateral ankle, and you're kind of palpating or touching that area and eliciting a little bit of pain. But the main goal is to figure out if they're stable or unstable.
Right.
Try to figure out, can this person bear any weight on this at this time? And then how do we best protect them, I think, right up front? And so, and you've probably done this in your practice, whether it be a strap brace or a boot, depending on how bad the ankle sprain really seems to be initially.
And do you get x-rays on all these patients?
I do. I mean, there's some criteria that we've sort of followed over time to do that, but most everyone's going to get an x-ray if you show up with a bruise and with some swelling in that way, because you want to be sure you're not missing an ankle fracture, actually, and sometimes those are lurking under there too, and you got to make sure you catch all of that.
Yeah, I mean, sometimes there are these little red herrings where patients will come in, they'll be walking on it, and they may have been to their athletic trainer and question whether they have a sprain or a fracture, and really, I mean, a lot of patients can walk on a fracture. So it's one of the things we always do is palpate the bones, and if patients have tenderness over the bone, then I think it's critical to get an x-ray. And most people who are getting to the level of an orthopedic surgeon's office are going to get an x-ray. What about MRI? Do you MRI all these patients, or how does that fit into your practice?
It's a great question, because sometimes that question comes from the patient.
Yeah.
Doc, I need an MRI.
For sure.
And it's not always the right move first. There are a lot of reasons to hold on that. And one is severity of injury, right? If you're looking at this, the x-rays are negative and we don't think you have a fracture, but we think you've got somewhere on a low grade type of sprain, that can be managed for a period of time. And often I'll manage that, and we'll get into the rehab things of this because that's one of the more important parts of treatment. But you can manage these for several weeks and sort of see how the patient evolves and see how they're able to participate in the rehabilitation programs. And if they are, then I'll hold on that MRI, sometimes till 6 weeks. Six
Right.
weeks, if you're not really better by then, I'm really thinking about pulling the trigger on that MRI.
Yeah, I mean, I would totally agree. So, a lot of these patients will show up. They may have seen their primary care doctor, or even some physical therapists or chiropractors or order MRIs these days. And I think that the thing here is that the reason to get an MRI in the acute setting or on that initial presentation is if we see something on the X-ray or find something on our exam that would indicate that there's some associated injury. So whether it be a tendon injury, some sort of fracture, cartilage injury, then those are the reasons that would push us to get that acute MRI. But I think that in general, the literature would support the fact that MRI is not indicated in most patients who come in with a lateral ankle sprain. And then, once we've determined you have a lateral ankle sprain, then the next thing is, how do we treat these injuries acutely? And what's your approach to this?
Generally, swelling is a big thing that you want to get down. I think people are more uncomfortable when they're swollen. I think that they have trouble with, the brace, the boot, all these things when their ankle is acutely swollen. And if you can get the swelling down early, I think that's important. So there's some different ways to do that. But I generally use some gentle anti-inflammatories, elevation, some different techniques to try to bring that down. Ice, Epsom salt bath is a good way to soak the ankle to bring down some of that swelling. Anything else you'd add to that list? I mean, it seems to be one of those problems that you're trying to get under control.
Yeah. Yeah, I agree. Sort of the RICE thing, rest, ice, compression, elevation goes for this injury, just like most of these acute injuries that we see as orthopedic surgeons. For a patient, and it's sort of patient dependent, right? I mean, we grade these ankle sprains to some extent based on the degree of injury. So an ankle sprain, I think, is sometimes it's difficult for patients to really understand what that is. And what it is it's a gradation of a stretch of your ligaments around your ankle to a partial tear to a complete tear. And what really sets people off is when they've went to their another provider, had an MRI, they come in with an MRI that says they've got a complete tear, right? And we've all seen this, and it's sort of a red flag for patients. At least it really gets them on edge. And when most people hear tear, maybe because it's they've heard of ACL tears or Achilles tears, and those typically end up needing surgery. Whereas in the ankle, a complete tear of your ankle ligaments doesn't necessarily mean you're going to need surgery. So, for a grade 1 sprain where we've just had a little stretch of those ligaments, and most of us will put them in an ACE wrap or an ankle brace and send them off with some instructions for rest, ice, and compression. Whereas those grade 2 and 3 injuries where we've had either a partial or a complete tear of those ligaments usually require a little bit more attention, and we'll typically immobilize those patients either in a brace or a boot for a period of time, just until that swelling gets a chance to resolve and they're more comfortable. A lot of the patients with a grade 3 tear may not be able to weight bear. So
it may take some time. So what do you think about treatment? Okay, you said there's a low grade, right? Grade 1 stretch, grade 2 is partial tear, grade 3 is complete. But grade 1, I think we sort of understand. You outlined it with the RICE care. What do you do, or how do you go about something you suspect to potentially be a grade 2, grade 3? Do you really tell the patient this is one or the other, or is that something you figure out along the way, or how do you attack that little bit higher injury problem?
Right. So it's a little difficult to tell, right? So in the patients who come with an MRI, we know generally whether they have a complete or partial tear or just a stretch. If it's a acute injury and they don't come with an MRI, a lot of times they're too tender to get a good examination. One of the things that we try to do for all these patients with ankle sprains is do what's called an anterior drawer test, where we sort of shuck the ankle forward or tilt it, what's called a Taylor tilt test, and that'll give you some indication of how much instability is at the ankle. Now, if they have a grade 2 or 3 injury, then usually you'll feel a little instability there. Sort of irregardless of the amount of instability in that acute setting, I think that the literature, the general knowledge would point to the fact that we're not going to rush these patients off to surgery. These patients still have a great chance of having a good outcome and not needing to have an operation to get there. For those grade 2 and 3 injuries, I typically will mobilize the patient just to let that ankle rest, let those ligaments start to heal in a position in which isn't stretched, right? Because what we're trying to do here is avoid that lengthening of those ligaments that's going to create that chronic instability. So I think most of these patients with grade 2 are going to have a boot or some form of immobilization for a period of time. Is that what you typically would do?
I think that's right. I mean, we try to keep that foot at sort of 90 degrees to the rest of the leg, right? For exactly the reasons you're talking about, to keep that thing from stretching any further. And often it'll be a couple of weeks in a boot, even potentially longer, depending on symptoms and swelling and those kind of things. And so one of the things I like to set up early with the patient is just preaching a little patience, right? You got to kind of walk them down this hallway, and it's going to take a while. Some of these guys are athletes. I mean, you take care of a collegiate team. Those guys want to play. They're built to play, right? When can I go back? I got to tell my coach. I got to do this. So you have to really work with the patient and really get them comfortable with the idea that this is going to take a little bit of time to heal. And part of the time frame is wrapped around your rehabilitation. So let's talk about functional rehab a little bit, because to me, that's the mainstay of care for an ankle sprain of any grade.
Right.
Especially if you're trying to avoid the operating room, you're trying to get this patient back together, whether they're an athlete or not, Let's talk about that a little bit. So what sort of things are involved in your protocol for functional rehabilitation for an ankle? What would a patient expect to be doing?
Yeah, I mean, I think rehab is essential here, right? So, regardless of what type of injury, that initial phase of treatment for these more severe injuries is to immobilize, let things calm down. And then the next phase is always rehab. And in the rehab, it can be done on your own using a home exercise program that's directed by your physician, or this is often something where we will get a physical therapist involved in the treatment of these patients, because that's their skill, right? I mean, they really focus, especially the therapists that I would typically send patients to for these problems are very skilled at ankle rehab. And it's focused on strengthening, right? So after we have these inversion injuries, for instance, the muscle gets stretched along that outside of your ankle that pulls your foot out, those everters, and they just shut down. And those muscles are the sort of the dynamic stabilizers of the ankle. And if we don't reactivate those muscles or strengthen those muscles, then not only have you lost some of the mechanical stability of your ankle by tearing your ligaments, but you also lost the functional stability of your ankle, or that dynamic stability. So I think, mostly, exercises focused on reactivating and strengthening those eversion muscles, and then what we call proprioception, or that ability to sort of, feel yourself in space or balance, is critical to rehabbing these patients.
Yeah, that's huge. I mean, the proprioception comes from the ligaments. They're at a certain tension, right? And so we don't want to lengthen those. But the injury creates sort of a mixed message to your brain. Your brain no longer realizes where your foot is in space when you're walking. So you have to retrain that. So you do a lot of balance work. After you get your motor things more activated, as you said, then you got to work on a little bit of balance, because the whole goal of all of that is what? Not to injure again, right? A second sprain is always going to be worse in most cases. It's the succession of multiple sprains a long time that leads somebody to that chronic instability, which is a whole nother chapter of ankle sprain problem. But the strength, the balance, proprioception, those things are the mainstay of that functional rehab program, which can be 2, 4, 6, sometimes even 8 weeks. And if you get into high ankle sprains, it can be 12 weeks. I mean, some of these things just do take a fair amount of time.
Yeah, I agree. I think that's the tough part for patients. Is a lot of patients have had, one of those walk it off type sprains at some point, right? They rolled their ankle, they, walked it off and got right back on the field or on the court and kept on going. And then, when you have one of these, grade 2, 3 type sprains that involves a partial or complete tear, the timeline's just totally different. And I think that, I try to set that expectation pretty early with patients that, this isn't going to be a walk it off type sprain. You're going to be, potentially off the field or off the court for up to 6-8 weeks, and it's going to involve a lot of rehab to get back to where you want to be. And then there's those patients who just don't progress, right? And at what point, do you sort of pull the trigger on, either ordering an MRI or exploring, different options for these patients with ankle sprains that just aren't getting better?
Yeah, I mean, in 6 weeks, if you're not really on track, I start to get concerned. Either concerned that we're not healing appropriately, or maybe there's some other underlying injury in there, because there can be. There, you mentioned cartilage earlier. There can be cartilage injuries in the ankle joint. There can be tendon injuries that are going along with this. So I start to get a little worried. We're really not looking where I want you to be at about 6 weeks. And that doesn't mean surgery necessarily in that moment, right? And get the MRI, see kind of what things look like, get the lay of the land, maybe better identify the severity of the injury. But it may still be another round of rehab that you're up for, though. If there's a partial tear, I think you still have a big opportunity to heal that on your own. And so we don't just get an MRI just so we can run off to the OR. That's certainly not the case.
Right.
Try to be strategic with who ends up in the OR, because it's a big change in somebody's life to have to undergo that, right? So we want to make sure we've given you every opportunity to heal and get better. The big question then becomes, all right, well, if I'm not going to have surgery, but I'm getting better, when can I go back to activity, right? The patient's doing CrossFit, or they're doing soccer on the weekends, or they're a major athlete, and they want to know when they can get back in. And I think that's where, as orthopedic surgeons, we have to deal with the term clearance.
Mm-hmm.
When are you, quote unquote, cleared to play? When can you go back? And let's get into that a little bit. How would you clear a patient, or when would you say to a patient that I think you're good enough to go back?
Right. And in my practice, I think in the setting that we see patients in, it's really difficult sometimes for us to make that call. I mean, a lot of patients want us to make that call.
Right.
And I think that's where it's so critical to involve either a physical therapist or athletic trainer in the rehab of these patients, because they see them in a really dynamic setting, right? I mean, they're watching them do their functional tests, their rehab, whereas we're in an office with limited space and constraints, and we can test your strength and have you do a single limb hop, and there's some very rudimentary ways to determine return to play, but I mean, there's not a whole lot of science behind that, right? So I think this is where I really, there's some sort of shared decision making by the patient, by me, recommending things, and then having a therapist or athletic trainer really, play into that decision. And I lean on athletic trainers and physical therapists a lot to help us with that decision, because when they sort of meet the functional testing requirements that the physical therapist or athletic trainer is administering, and I would say generally when you're 85 to 90% of the normal extremity, when your functional tests have met, that criteria, then I would say you've met criteria to return to play.
And that's sort of the way I look at it too. And I think I try not to use the word cleared to play directly
Right.
with the patient. It's sort of, I'm telling you that you have healed functionally well enough to go back and start to do more sport specific activity. Whether or not you're ready to go into the game is a function of how your trainers see you, how your coach sees you, and where you are. Because during this time, you may have lost a little bit of that edge that you need to get all the way back before you can perform at a high level. And I think there's an important distinction for that. It's not our job to say that you are absolutely ready to go into the game and start at whatever position you're in. It's for us really to determine whether or not you're safe to go back and start to do more sport-related activity.
Right. Yeah, I think that's so true. I mean, and especially at the higher levels like collegiate and professional sports, I think that's where the athletic trainer and physical therapist are really even communicating with the coaches at that point, and helping the coaches to determine when that player is ready to return to play, because it's really not a decision that is as simple as black and white as like, you're ready or you're not ready. This is involves a lot of functional testing and watching the player play before they return. So
Agreed. And these things, as we've sort of lined up for you can be a little more complex sometimes. Sometimes they're a little more simple, but it's definitely a spectrum. And I do encourage anybody who has an injury that they're concerned about to seek some medical professional advice and help, because the last thing I'd want anyone to do is to have that walk it off one, and then the next time they injure themselves, oh, I'm just going to walk this off, and then never
Right.
really get checked. Because if you get too far behind on that, I think it's difficult to catch up. I think that's where you can get into a situation where it's been a long time. Now you're stiff. Now you have a lot of weakness, and maybe even you're one of those 20% of people who now is developing chronic instability,
Right.
which is a whole nother bag. And so, if you have pain and swelling and bruising, I encourage you to get checked out. And guys
Yeah.
like Mike and I are here to help with that.
Absolutely. Yeah, I think that's important what Tagg just mentioned. I mean, the majority of people are going to get better, 80%, right? But the literature and in our research would point to the fact that about 20% don't. And if you're not better within, 2 or 3 months of your sprain, then you absolutely need to come in and have us take a look, and we'd be happy to do that.
Absolutely.
All right, we just want to thank everybody for watching this portion of the Game Ready series. It was great, helping to inform you guys on some of the common issues we see with ankle sprains. So just to remind you, I'm Mike Greaser, practice in Sugar Land, Bel Air, and the Med Center, and would be happy to see you. This is Tagg Gauvain, and he's going to be in Pearland, and we are here for all your foot and ankle needs.
Yeah, don't hesitate to look for somebody to help you if you're an injured person. So we're glad you tuned in, and thanks for being here.